Okay, Tiffany, you may begin whenever you're ready.
Okay, so thank you for having me. My name is Tiffany. I work with East Point Prosthetics and Orthotics. So today I'm just going to talk a little bit about my company and what we do for a service, and then I have some information about diabetes as well. So who I am, I'm a CPO certified in both prosthetics and orthotics. I graduated from Northwestern from O&P school in 2005. My majority of my career professionally has been in the Pittsburgh area. I did work briefly in Ohio, but I'm back here. My husband's from this area. So I'm originally from North Carolina, actually. And I've done some adjunct work for the University of Pittsburgh, and I actually am still there. I've been here for, I think this is my 8th year there. So it's kind of a nice balance. So I actually only work about part-time with East Point, and then the other time is spent at the university. So a little bit about East Point. So it started in North Carolina, actually in eastern North Carolina in 2008, and it has since grown Raleigh area and over into Ohio, and then most recently they opened up in Pennsylvania, physically in Harmony. But the real, I don't want to say motto, but a very much like a mission statement of the company was to meet people where they were, regardless of transportation issues, to provide quality of care. So that's why I put this picture in there. If you ever go to their website, you'll see this picture as well. So it shows someone working with someone outside, which is kind of nice. Like if you ever get to see a patient outside or work with people outside. And she's working on someone's prosthesis. And in the background, there's a mobile van. So in the back of that van is all like an equipment for basically like a mini office. So if you ever go to an O&P office, there's like machinery, grinders, and heat guns, and glues, and usually you have like a smell too. So that's kind of like in the back of their vans. I do not have a mobile van, and my coworker and the Ohio group doesn't have vans because they figured when it was winter and going to people's homes, they couldn't get out very easily sometimes. So they had to go with, my coworker has an Explorer, so he doesn't have a mobile van, but that's all decked out with everything that he needs.
That's fun.
Yeah, it's kind of neat. Like, I've never worked for a company that just put everything in the van and you just kind of drove around and did your thing, you know. And now scanning is a lot bigger instead of casting, which casting is still done a lot, but sometimes there's digitizing and scanning so that you don't even have to take things back to an office physically. You can just scan it in and then can print it. There's 3D printing too, which is kind of neat, but it only works. It works in some situations and not in others, so it always has to benefit whoever we're seeing. So a little bit about Harmony, our East Point location in Harmony. It's in Harmony, like Zelienople, Harmony area. That's our physical address. Kristen is our patient care coordinator, or she handles like all the paperwork, so if you ever call the office, that's who you'll interface with. And then my coworker is Brett Decker. So he is actually from, I believe it's Indiana, PA. So he's from this area. He went to the University of Pittsburgh. He had moved down to North Carolina, did his residency there, and then I think he just wanted to move back home. And so he really believes in the company model so much that he didn't want to move back home and checked into another company. He just said, hey, let's try and open up an office. So that's what the owner did, which I thought was really nice. Actually, and I know the owner of this company, even though he's in North Carolina, because that's where I'm originally from, and I did my shadowing hours before I went to school with him. So before he even opened up East Point. So that's how I knew of him and of this company, instead of just kind of blindly applying to places and not knowing So services we provide, you know, if you've ever been to another orthotic and prosthetic facility, we provide basically the same things. Anything head to toe, anything you can brace, anything you can put a prosthesis on. So partial feet, below the knee, transtibial, transfemoral, above the knee, fingers, hands, below elbows, above elbows, that kind of thing. This is kind of a neat story. Let's see if it'll open.
Oh, you wouldn't happen to have those fingers, would you?
No, I know. I don't have those. You know what? They came.
I would love to have fingers.
Yeah. So this was just a story that is on their website.
Drawn the trail. I was 36. I found out I had peripheral vascular disease, and they took my first. They had to take my second leg when I was 37, about 8, 9 months. And I had to take my first leg. I went through one company, and they made me some legs that didn't do me any good. The way they were held on, they cut more circulation off, and I was already had lost. The other legs that I had made, they were held on by suction, and when I would get skin breakdown from them, and with the bad circulation, it would take 8, 9, 10 months for, you know, a small sore to heal up. Then when I got here, I got hooked up with East Point, and they have gone above and beyond making me some legs that work for me. These, compared to the other ones, it's like night and day. I mean, I had gotten to the point I didn't think I was ever really going to be walking again.
He's below the knee, isn't he?
Yeah.
Yes. Yes.
Now I've got hope again. I know I'm going to be walking again. You know, I walk every day. You know, I practice a little bit every day. I just, you know, have to kind of take it slow. It's been so long since I had, you know, any legs. These legs are half the weight of the other legs also. I was going to mention that. And that makes a big difference too, especially trying to go up steps and stuff. The others are like, having 4 or 5 steps, it's like lifting bricks. It's been amazing to me, and the knowledge that y'all have given me. The other companies that I've gone through, they never even mentioned anything like this, or never even mentioned none of the other ones that we talked about in case these didn't work. But these, the way they hold on with the side, rather than putting all that pressure on the nubs, where I don't have good circulation anyway, it's made all the difference in the world. It's nice to be able to walk, and I'm going to get better and better with them until I'm totally out of that wheelchair.
So I just wanted to show y'all a video that's on East Point's website, which there's other videos too.
What's
On
the
there.
overall size of the company?
So they have, so since they're more mobile, there's not as many physical offices. So there might be like 4 or 5 like brick and mortar places, but the number of practitioners I think is around 15. So like a little bit smaller, but since 2008, I mean it's a pretty good size.
Yeah,
for that one.
I think since Delatory and Union merged,
Oh.
there are about 150
Is
people in their group
yes, and then I thought
in a total, different
yes,
from the janitor to the
right,
CEO.
right, yes, yeah, because they were
Who's a young lady, by the way.
I'm sorry?
She's the young lady.
The
The
CEO
president.
of Union.
Oh, yes, Laura, right?
Yeah.
Yeah, Laura. She's a lime cooler too, I believe.
She's what?
Her last name was Lime Cooler, which is the lime coolers who started Union, I believe. Yeah, it's all very interesting. She comes to Pitt too and talks about, I think we had her come and talk about creamy marmots as well. So I like that video because it shows, another side, and then it shows how, he's walking outside again and he's, in his environment too, which my coworker could really speak a lot because he's done so much more with, mobile visits and home visits, and how when you go into someone's home, it's different than when they come into the office, because then sometimes you get to see their environment. You get to see, oh, you have steps here and that's difficult for you, or you have throw rugs and on your hardwood floors. So it's, and then sometimes in the office not all the family comes, but there are sometimes other siblings that live together. So like a pediatric patient, instead of just the mom or the dad or the grandma coming to bring them to the visit, now you have other siblings looking to see how is that put on, so that maybe they could help their little brother or sister get their braces on. So it's kind of neat in that aspect to go into someone's home and see their whole environment to treat them a little better.
Do you pay more for that service?
No, they do not charge for that service. Mm-mm.
I mean, you'd have to account for the driving, the getting to and from.
Yes, so that is a part, it's in our schedules, but it's not passed on to the patient. It is, company vehicles that they were providing, but,
Sure, yeah.
and there's been no charge that I know of that's been passed on to patients, and it was really driven by the owner saying, and having a conversation, I think, with the now vice president of, especially bilateral amputees, he's like, why wouldn't we go to their home to provide them a service? It's really hard for them to get out. And then there are other times, you can say people have access, or the access vans that bring them, but sometimes they're limited to how many times per month they can use that, and usually they're using it for more, they have to prioritize, this doctor, that doctor, and then, prosthetics and orthotics, sometimes you have to come back multiple times. So it was a way to break down a barrier to better patient care that the owner felt needed to happen. So orthotic services, we provide anything head to toe. I always love it when there's pictures of people in braces and they're smiling.
Wouldn't head to stump be better?
When what?
Head to stump.
Oh. That is true. Maybe I should change that for next time, head to stump. Yes. But yeah, I love it when people smile when they're in their braces, because usually people don't tend to smile when they're in braces. Prostheses, I've had people get up and walk and they're happier. But normally a back brace or a neck brace, they're just kind of okay, thanks, bye. But anyway, cervical collars, low back pain, lumbar braces, wrist splints carpal tunnel syndrome, or elbow splints golfer's elbow or tennis elbow. So anything kind of you can think of, you probably do.
Drop foot.
Yes.
I have one on.
Yes. Yeah. we do that. Custom, off the shelf, anything. So it's different like than a DME provider like Blackburns or Clean Smiths, where you can go in and they'll sell things off the shelf to you. But I don't believe they have anyone there to do custom. And then we do anything for the feet, so arch supports, therapeutic shoe modifications, anything that's needed there. So I wanted to transition and talk about a little bit about diabetes and how that is in the orthotic and prosthetic realm and kind of what we do about it. So the CDC statistics, and if you've ever used the CDC, you can look it up to do any disease and it will tell you like the incidence. It's not very user-friendly as far as for the general public, but it's kind of a nice tool if you're looking for something specific. So like this says there's 1.4 million new cases of diabetes that were diagnosed in 2019. This was their newest information. What I found interesting too was the number of adolescents and children. So for type 1 diabetes from about 2002 to 2015, it's basically was a level line. There wasn't really much increase or decrease. So that's the type 1 is more what they used to call like juvenile onset. Type 2 is more adult onset. But if you look at the other graph for the type 2 diabetes, it's going up for kids that are 10 to 19 years old. So it's kind of alarming. And the top line there is for the Asian Pacific Islanders and non-Hispanic. White non-Hispanic is the bottom line. And then the black dotted is like your overall. So we're seeing a trend in diabetes kind of across the board, just going up. So diabetes, usually your healing wounds and rate times are increased. Annual incidence of diabetic foot ulcers is 0.6 to 2.2%. And considering we're adding 1.4 million new cases a year combined with what already exists, like that's a pretty big number actually. And then there's some data that indicates that diabetes accounts for the majority of the non-traumatic lower extremity amputations for most parts of the world, and that 75% of those amputations were preceded by a diabetic foot ulcer. So there's some risk factors involved. One risk factor involved is having diabetic peripheral neuropathy. So this is how you can have decreased pain or no pain, and pain is a protective sensation. If we touch something and it's hot, we want to just grab our hand back. But if you don't have any sensation there, you can just hold on to something hot and it won't bother you until like maybe you smell something or that kind of thing. So that is a risk factor, having loss of protective sensation. Also with peripheral neuropathy is seen at times decrease in muscle or muscle wasting, and because of that muscle wasting you get like foot deformities in the sense that your muscles aren't doing their jobs to kind of like hold your foot up in the right position and support your arch, so then your foot kind of like relaxes. You might get some abnormal distribution of pressure because your foot is set up as a tripod, and that's how it distributes pressure. So again, risk factors, another risk factor includes deformities and limited joint mobility. So I like these pictures as well. So the one on the left, you can see has more of like a bunion or a prominent first metatarsal head or ball of the foot. So sometimes that can rub inside the shoe. The other side you can see is like has some swelling, and the picture's a little bit better on my screen. It's actually reddish too, so there could be some infection there going on. But other deformities are like a rigid toe. So the great toe actually needs about 65 degrees of bend to be able to walk step over step. Isn't that, yeah. But if that's not there, then your body figures out another way to get you from point A to point B, and it just worries about the consequences later. It says, right now we're gonna do this, and we'll worry about it later. But then with that, if you transfer motion somewhere else, you can get rubbing again, or breakdown. Restricted movement of the ankle. Again, if you can't move your ankle as much, another joint has to kind of take its place, and a lot of times that goes down into the foot, and people, like their arches will kind of collapse. But again, the body's just saying, I'm gonna get from point A to point B, and we're gonna worry about the consequences later. If there's decreased fat pad underneath the balls of the feet, again, that's just protection. It's kind of here in our hands too. So if you can imagine, like if there was no fat protection right there, you might be prone to break down. Thickening of skin, tendons, and ligaments too are risk factors. Sometimes you'll see people like, that isn't too bad, that swelling, but if the swelling gets bad enough, and maybe there's some lymphedema going on, and like the skin will become like thickened, that's a risk factor as well. Also, just regular walking around, trauma, if you stub your toe, if something falls on your foot, it's always good to wear shoes. I had a hammer fall on my foot once. It was bad, and I was not wearing any shoes. My husband had his tools out on the dryer, and they were on a towel, but I had folded the towel up so that I could get in the dryer, and then I forget exactly what happened when I came back, and something happened, and then the hammer ended up falling on my foot. I thought I had broken my foot.
Yeah.
It hurt really bad. But anyway, so that could be a risk.
You ended up with hammer toe.
No, I didn't, but I did wear a boot for a while, and I did get it x-rayed because I thought, oh my gosh, this has to be broken. Yeah. So risk factors against self-inflicted, but this is more like not trying to hurt yourself. This is more like cutting your toenails, and if you don't have as much protective sensation, how do you know if you're nicking your skin or if you're just getting the nails? Improper shoe wear, rubbing in shoes again. One study collected information from 669 ulcers and found that 21%, so almost a quarter of those ulcers were from improper shoe wear. There's an education and self-examination too, and the Mayo Clinic actually put out a whole thing, and if you would like more information on their, they go over all these key points and tell you like little tidbits about that, and I can probably get that to you, you can pass that out, but it talks about awareness and understanding, and just knowing, if you have loss of protective sensation, and if you're at risk. Tells you to avoid injuries by basically, wearing shoes or slippers too. Inspecting your feet daily. I think that goes across the board in all parts of medicine. I know my doctors will ask me, have you done self-examination? Dermatologists will ask about, examined your skin. It goes with, just regular good health. And especially if people are diabetics, daily foot inspection is good. Even people will have mirrors on sticks, or they'll place a mirror on the floor so they can look, get a flashlight, or someone whoever they live with maybe will, look at their feet as well. There's good feet hygiene too, so wearing socks with shoes, making sure that when you wash your feet that you're doing so with mild soap and water, and you're getting in between your toes, and that you're drying in between your toes. And then if you are putting lotion on your feet, it's like a non-perfume, non-alcohol base, and that you don't put lotion in between your toes. So clean between your toes, no lotion in between your toes, and inspect between your toes. Sock selection, I thought it was kind of neat. The Mayo Clinic brought up the fact of maybe wearing white socks if you're diabetic and have ulcers, because then if you do have a cut or scrape or something's oozing, then you can see it on the white sock better than you could a dark sock. They talk about socks being non-binding, which some doctors will write prescriptions for socks, and usually people will go to Blackburns or Cleaning Smiths to get them. And they're just softer, non-binding socks. Sometimes they have no seams in them to help with any type of rubbing issue.
What about compression socks?
So that's a whole different thing. So if someone is diabetic and they need compression socks, then those are prescribed for them. But just being diabetic doesn't mean that you wear compression socks. Does that answer your question?
I wear them, and I'm a diabetic. So
And you wear compression socks? Okay, but your doctor has recommended that you wear.
Well, my feet swell if I don't wear them.
Okay, yeah. I mean, I don't want to recommend something other than what your doctor. If your doctor has you wearing compression socks.
I don't know if I've ever discussed it with them.
Oh, okay,
I'll
okay.
bring it up. I'm seeing them on Halloween.
Yeah. I mean, I sometimes wear compression hose for my varicose veins, but it's not contraindicated. If you're diabetic, you're not supposed to wear compression stockings. I think what this self-education and examination was getting at was just making
Where's
sure.
it for the fluid retention though?
Yeah.
Yes.
Yeah.
So something probably different than your diabetes. But, there's nail care as well. So again, they talked about if you do trim your own nails, which some people go to the podiatrist, but if you do trim them straight across, and then file any rough edges down, so that you decrease the risk of nicking your skin or cutting a little too far.
Yeah, the insurance permits nails to be cut
Yes.
on every 9 weeks or so
Yes.
as a diabetic.
Yes. Yeah, which is good, because sometimes that becomes an issue.
Is that done by your podiatrist?
Yes. No, by a foot doctor. Is that the same? I'm sorry.
Yeah, the podiatrist.
Okay.
Mm-hmm, okay.
I went somewhere else.
That's all right.
I'm
No,
sorry.
that's fine.
Podiatrist and
Physiatrist
Prosthetic.
and
Yeah.
dermatologist.
Everything, yes. Footwear selection is key as well. So footwear selection, footwear fitting. So if you are diabetic, but you're not qualified for diabetic shoes, which we'll go over the qualifications, it's best to get a shoe that has room in the toe box for you, and your widest part of your foot lines up with the widest part of the shoe. So what we mean by that is you can kind of see where the widest part of my shoe is, about right here. So I want to make sure, and it's almost where the balls of your feet are. So the balls of your feet should basically line up with the widest part of your shoe, and then you should have room to kind of wiggle in between there. Something that fits well, something that you're not, coming in up and out of. Something that's lace or Velcro strap is usually recommended better than something that just slips on. And if you ever need to go to a health provider for support, please do so. And then ask questions. That's what this education and self-examination from the Mayo Clinic suggested. So just a little bit about diabetic foot ulcers, and this is one classification system. It was called the Wagner classification, and it goes through stages of like 0 being no ulcers there to like the last stage being like gangrene, nasty, and basically it was developed as a tool for physicians or podiatrists to use to say, okay, how should we treat this? What's the most effective way? And there's been studies done about, well, if you have like stage 1, you know, maybe just a dressing, but as you go on, you might need debridement, you know, or surgeries and that kind of thing. So some testing that you might have done, there's a number of different ways to test sensation. So these aren't the only 2, but these are fairly common.
My doctor does that. He has a little
Yeah.
thing that he
Like a
touches
little
the
prick
bottom of
thing.
Yeah.
Yeah, it looks almost like
Can you-
fishing
yeah,
line.
And then you
Yeah.
close your eyes and
Yes.
see if you can feel that.
Yes, and we always tell people to close their eyes or look away, because if someone's looking, and I've had it too, like they'll tell you where it is, and then if they look away, they'll say, no, it's on the heel, and I'm tapping their great toe, you know. So one is called the Weinstein monofilament, and that's what it is. It's like a, you know, couple inches worth of almost like fishing wire type looking material, and you prick it, and when it starts to bend, that's when you should feel it, or when the patient should feel it. And then usually they have it, they do it on the feet, and they work from the toes up to, you know, the heel, your ankle, and see, you know, if you can't feel at the toes, can you feel more towards the heel, at the ankle, or is there total loss of sensation? There's also ones like it's a 2-point, 3-point, you know, can you detect the difference between just like 1 point of sensation or 2 points of sensation? There's all these little things that it's all tricks. And then you can actually use a tuning fork as well. Now sometimes tuning forks, I always think of them as like auditory, like that's, they test for auditory. But there are ones that you can use to test sensation. So what you do is you bang it, not bang it, but hit it to make it vibrate, and then touch it to the patient, see if they can feel that, and then let them tell you when the vibration stops as well. So they need to be able to sense the vibration and sense when it stops. And then from my understanding, this tuning forks can also be used like in ERs or something like that. If someone has a fracture and they can't detect it on an x-ray, if they use a tuning fork, the vibration, if that elicits pain, it's not the best way, huh? But that will be indicative of a broken bone or fractured bone. So the more you know, huh? So diabetic shoes. So again, the criteria of a diabetic shoe, and I put the picture of the tennis shoe type looking, because diabetic shoes can look almost any way that you want them to. They can be, you know, your classic loafer walking, or they can be like a snazzy, colorful tennis shoe. What makes a diabetic shoe, or really they're called therapeutic shoes, or as one of my patients called them, is sugar shoes. You got your sugar shoes on. It has to have a wide enough toe box. It has to have extra depth, or depth that accommodates an insert, and it has to have a qualifying insert in it. So this is a picture of a qualifying insert. So it has to have multi-density, so 2 or more layers. Usually it's between 2 and 3 layers that you'll see on an insert. And then the top layer has to be a plastizote material, which has been studied and found to decrease risk of ulcers in diabetic patients.
Plastic?
Plastizote. So it's a pinkish looking, do you have one in there? That seems a little old. I'm not sure if that's plastisode or not on the top of that.
It just came with the shoe.
Yeah, it's a,
It's just a regular tennis shoe.
oh, okay, so it's a pinkish looking type of material. And what most insurances will do is they will pay for 1 pair of shoes and 3 pairs of inserts per year, so that you kind of wear them out evenly. I know that if you obtain some things through the VA, that they actually provide 2 pairs of shoes and inserts per year as well. So, any questions about that? Okay, so to qualify, for someone to qualify for diabetic or therapeutic shoes, they have to have a diagnosis of diabetes, and they have to be being seen regularly by their doctor who treats them for diabetes. So whether that is an endocrinologist or whether that's just their regular PCP, you know, whoever treats them for their diabetes, whoever manages that, and they have to be seen within the past 6 months from that prescription that we get. And then on top of that, they have to have a qualifying foot condition as well. So some type of foot deformity, and there's, when doctors fill out the form, there's a number of foot deformities on there. I wasn't going to read them all off to you, but a history of partial or complete amputation of the foot, a history of preulcerative callus, peripheral neuropathy with evidence of callus formation, and then poor circulation, classified maybe as a peripheral arterial disease or PAD as well. So that kind of qualifies people. So some people, you know, they do have the diagnosis of diabetes, but they have no loss of protective sensation. They're otherwise healthy, their feet look healthy, and they don't qualify. And then there was a story, it wasn't my patient, it was one of my coworkers that I believe they had a pancreas transplant, and then they weren't diabetic anymore.
Yep.
Yes. Do you know who I'm talking about?
I don't know.
No. Okay.
No.
But I remember that, and they were like, oh, I can't get my they couldn't get their diabetic shoes anymore because, you know,
They had what?
they weren't diabetic anymore after
After what?
after the pancreas transplant. So they were diabetic before,
Okay, yes,
and then they
sorry,
got a new
yeah.
pancreas, so then their pancreas produced insulin and worked as it should, so then they didn't have that diagnosis anymore, so they couldn't get their shoes anymore.
That's one of the items that they transplant, one of the organs that they transplant?
I
The
guess.
pancreas?
Yeah,
Oh,
I guess I'm not an expert in transplanting, but
Only transplant delivery, you don't have hemophilia anymore either.
so.
Sometimes it helps. Mm-hmm.
Yeah, it's pretty incredible. I was gonna say one more thing.
and, you know, because with pancreatic cancer, it seems like that would be an option of curing it. And that's one of the worst, obviously the worst,
Yeah,
one of the worst cancers.
yeah.
I didn't know that they
Yeah,
looked it up.
that's the only person that I've ever heard of,
Yeah.
actually, now that you bring it up.
Oh.
But I don't, that's interesting, I'll have to look that up, like, how many transplants
Pancreatic
are done.
cancer is pretty far along by the time it's found. It's either 3 or 4.
Yeah,
And there's no pain with it to begin with. It's there, it just grows.
yeah,
And then all of a sudden you got it, and it's horrific.
and then that's it, and it maybe metastasized too, to the point
Yeah,
where
by
you
that
can't
time
even get
it's-
like a transplant.
yeah.
Yeah.
Mhm.
Aw, that's sad. So my one last word is prevention. You know, you have diabetes, just look at your feet, you know, do your preventative things, exercise, all that kind of good stuff. Ask questions too. So if you feel like, oh, well, maybe I should ask a question of whether I qualify for shoes, because I've had an ulcer before on my feet. the other thing that I wanted to bring up too is if you ever have your nails done, not by the podiatrist, but I know of some people who have them done like for pedicures or things like that, just ask, is your equipment clean? Ask the good question, because sometimes like maybe they didn't clean it off. So ask good questions. And then keep your appointments for routine wellness visits. You know, even with O&P services, just because, you know, you don't need anything new doesn't mean maybe like, oh, you know, I can get a new strap, or I can get, you know, whatever you need to get, new liners or things like that, that are routine. They're not like the big product, but you can get, you know, refurbishments, replacements, cleanings, new straps, that kind of thing, between getting, you know, the bigger product. Any other questions?
I have one question about orthotics. It's something that comes up often. People wonder, should they have one? If so, do they need to see their doctor first for a script? And what sort of things do orthotics help with if they're looking for one inside their shoe?
Okay, so inside there's like inserts
Yes.
for their shoes.
Mm-hmm.
So they can always be evaluated for, you know, our services without a prescription, and there's no charge for that because our field charges per device, if you will. When you get a device, then insurance is charged. Sometimes you have to check with the insurance carrier, especially for inserts, because some insurances will pay if you're diabetic and then nothing else. Some insurances will pay if you have plantar fasciitis, but no other diagnoses like arthritis or, you know, you just need support or anything like that, or metatarsalgia. So it depends sometimes on the insurance contract as well, like which insurance that you go with. But yeah, asking the doctor, you know, when you go for your routine visit, or just bring it up, and then see the coverage on the insurance. You can come. You can also come to one of our offices or any O&P office and bring that up, and they can check into, usually front office staff is well trained, and they can check into insurance coverage and let you know as well.
You say you charge by product or by?
Yes.
Okay.
Yeah.
Once a leg is fit and additional visits are needed, are there charges for that, or is that included in the initial price?
So that is, there's usually what's called like the 90-day kind of warranty or window after something is dispensed and you've signed for it, that any type of adjustments or things like that is covered for. And then after that 90 days, they just take it on a case-by-case basis. Like, is it wear and tear? Is it natural wear and tear that, you know, can be charged like a labor fee or a small parts fee, you know, or is this, you know, maybe it was a manufacturer's defect and we need to go back to them.
Or patient abuse.
Oh.
Some of the, we share time with other amputees at training sessions
Yes.
for universities, and some of these fellas, you wouldn't know they have prosthetics.
Yeah.
They do darn near everything
Right.
with them. You know, they're hunting, they're bike riding, they're, you know, like I said, what would happen if you damage one of them in one of these extracurricular activities?
Oh, okay. So if it's not under warranty, yeah, sometimes like you might have to battle with insurance to get something else paid, or I feel like a lot of times the company would work with them, or they would go back to the manufacturer and say like, hey, you know, this is what they were doing.
This guy did some skydiving and it broke when he hit the ground. No, that's a made up. So you go back to the insurance company with that and say, oh,
It might Yeah, that it broke and it's not fixable,
Exactly.
you know, within our time frame. And then a lot of times, if you do have a patient that's very hard on their product, then you either get them a better product or something that stands up with them. You know, you call the manufacturer and say, this is what I've got, this is what I've tried from the company, what else can you provide? And sometimes they'll work with you to provide the best that they can for